So the topic is arthritis, and arthritis, the most common joint that affects is knee joint. And you all know that knee joint is very versatile. We do a lot of things. We have to get up and move every day. So it's one of the complex joints in our body. It can do multiple activities like flexion, extension, rotations. And because of that, you're able to walk, bend, jump. Most of the activities involves knee joint. And because of this complex range of motion and it bears your weight, it is also very vulnerable to injuries. So if you look at the knee joint anatomy, that is what comprises of the knee joint, we have multiple bones. There's the patella, the kneecap, the thigh bone, which is the femur, the tibia. In between, we have the two shock absorbers called the meniscus, and we have the stabilizers called the ligaments, the front, the ACL, back PCL, and the two side ligaments called the collateral ligaments. And all this form the knee joint. And the building blocks for this is the muscles, which is the quadriceps in the front and the hamstrings in the back. So when all these are in harmony, are they working together, then your knee joint is healthy. Okay. So of all ages, people of all ages, they complain of knee pain for one or the more reasons. So most of the reasons could be from above the knee, which is involving the muscles, like this, the quadriceps muscles, or it could be fluid within the joint, that's called bursitis, or it will be at the level of the knee joint, where it could be some kneecap problems or kneecap tracking problems, or could be a repeated stress fractures, or it could be arthritis. It could be even your fat pad, which is the fat covering and protecting their structures. Now they can get impinged because of some injury, old injury. And below the knee also there are some problems with the patella tendon, or by growth, if the bones are not grown properly and they are irritating your tendon, then that can also cause osteosclerosis and other conform diseases. So this is the diagnosis chart where different diagnoses can be around the knee. So behind the knee, as I said, could be a muscle-related tendinitis, could be a cushion injury, could be a kneecap wear and tear that's called chondromalacia. It could be fluid accumulation called the Baker's cyst, or there could be ligament injuries, or on the inner side of the knee, it could be a plica syndrome. It could be, again, arthritis. Arthritis can also be osteoarthritis, or it could be inflammatory arthritis like rheumatoid, or it could be a collateral ligament injuries. And there could be some fluid in the collection in the muscle also, which is called as sensory bursitis. So there are wide reasons why one will get a knee pain. And not all knee pains are arthritis. So there are different reasons. So proper history and proper symptom assessment and clinical examination with some investigations will help us in finding out the correct reason for your knee pain. So this is some of the sports-related IT band syndromes, where long-distance runners, joggers, they have this problem called IT band syndrome, which can cause pain on the outer aspect of the knee. Or it could be a small injury, like a bike injury, or you hit something, your cot or your table, and you have some contusion. And all these can lead to fractures, injuries, and even fractures, which is around the knee, which is the periarticular region of the knee. Even they can cause knee pain. And some hairline fractures goes unnoticed, which causes chronic knee pain. So the causes of knee pain could be injuries to the knee, it could be mechanical problems, it could be a medical condition. So some of the common knee injuries which occurs are the ACL, which is commonly very known to everybody. It's called as the ACL ligament injury or the meniscus injuries, and some fractures. So this is the meniscus injury. This is the ACL ligament where the ligament gets torn, or it could be a fracture where you can see there's a fracture happening, or it could be some tendinitis, where these are the tendons, these are the patella tendon, and fluid around this joint can also cause knee pain. So when you look at the healthy knee, everything is aligned. But when you look at where some of the structures are damaged, you will have some malalignment, where the kneecap gets malaligned, or the knee itself gets malaligned, or there could be rotation, or even if your foot is flat, to compensate, your knee can go into various alignment and cause knee pain. Or you could have an old injury, and there could be some loose fragments floating in the knee, which you may not notice, but over a period of time, they cause rubbing and cause friction in the knee and cause arthritis. So medical conditions, as you know, One is osteoarthritis, or they could have some increased uric acid. Now a lot of people take protein intake, protein shakes, a lot of non-vegetarian red meat. They have grown to have uric acid deposition, and increased uric acid causes crystal deposition, and crystals damage the cartilage. A normal cartilage and a broken down cartilage, and eventually these are like shock absorbers. Once the cartilage goes, and then your bone comes in contact with the bone, and that is what is arthritis. And usually in osteoarthritis, only the weight-bearing zone gets affected. But if you have a medical condition like rheumatoid or a gout or any other form of arthritis, the entire joint surface gets inflamed and cause arthritis. So this is a kneecap problem, very common. People who do knee bending activities, a desktop job, climbing stairs, a knee bending yoga. So all these will lead to what is called as a pain in between the kneecap and the femur or the thigh bone, and inflammation and breakdown of cartilage is called chondromalacia initially, which eventually leads to arthritis. So what are the risk factors? The risk factors are people above the age of 50 and female patients usually who are above the age of 50, 55 and who are overweight, whose body mass index is more than 23 to 25, and who have a knee joint injury which is not noticed, which neglected, and eventually it leads to wear and tear, or repetitive strain, jobs which involve repetitive strain like contact sports or lifting heavy loads or sitting on the floor and working. So they also have repetitive injuries, or people who are long distance runners, or they can have a stress fracture and that can cause arthritis. Or if the joint structure is mechanically malaligned, like by birth some deformity is there, or some old injuries goes unnoticed, like a ligament injury, and the joint is not in alignment, then that can also lead to arthritis. So ligament injuries, as I mentioned, common is the ACL, then comes the PCL, which is behind the knee, then the two collateral, which are the side ligaments. The mechanism of injury for ligament is either a twisting or a hyperextension injury, or it could be a direct blow, or it could be an accident, or it could be just a fall on the bent knee, which leads to damage to the soft tissues within the knee joint. When you look at the symptoms for ligament injury, it's commonly pain and swelling and some bruising, difficulty to move the joint, and sometimes the knee gets locked in a cushion tear, and the patient will not be able to put weight. And initially with icing, this might settle. And once the patient feels better with medications and icing and he starts doing his regular work, the symptoms get worse, and then they have to get investigated. So this is the meniscus. This takes the entire load of the knee. So when the patient walks, it's like he's walking on the meniscus. So there is a layer of protection called the meniscus, and above that there's a layer of cartilage, and then comes the bone. So for a person to develop arthritis, the meniscus has to wear out, the cartilage have to wear out, and then the bone on bone comes in contact, and that is the last stage of arthritis. So it's a very crucial thing, the meniscus, because it takes the entire load and distributes the load. Various patterns of meniscus tear can happen. This is a simple twisting injury. Even you get up from a Indian toilet or squatting position, you can have a rotatory force and you can develop arthritis, meniscus tear. And meniscus tears usually goes unnoticed. Patients usually are able to take some painkillers and manage their activities. But this will be a chronic pain. Whenever they squat, whenever they bend the knees or do some yoga, they will again get the pain. And most of the people they ignore, they don't present immediately. They usually come a bit late. And it could be a sporting injury, or it could be a small twisting injury like any household chores you're doing and your knee gets trapped. Or it could be age-related, that is post-arthritis. There will be rough bone which can damage the cushion, and repetitive damage to the cushion can lead to degenerative tears in the cushion. So how do you know if you have a torn meniscus? The common symptoms are swelling, you have a restricted range of motion, you'll have frequent popping and clicking sensation, and you have locks. The knee gets locked. You're not able to straighten the knee. You're only able to bend, but you're not able to straighten. So these are the symptoms which caused by meniscus, and that can cause pain. So common sensation is that the knee is giving away, either because of the locking or because of some associated ligament injuries. So when you look inside the joint, like when you put a camera, there's an arthroscope, and look inside, So this is how the meniscus is, and the meniscus gets torn either in the posterior horn, that's the backside, or in the body of the meniscus, or in the front, or at the root. The root is where the meniscus is attached to the bone, and it gets its blood supply, and it's stabilized at the root. Now, if the tear at the root is sometimes not picked up even in the MRI, so very high resolution MRIs can pick it up, and you should not ignore a root tear, because if a root is torn and the meniscus is detached from the root, it's as good as you not having any meniscus at all. And the entire load is taken by the cartilage, and your chances of arthritis is very high. So of late, the root repairs have come into focus, and we are able to repair the entire root, where we tie the root to the bone. Usually when the meniscus is torn in the front or in the back, this is how we stitch the meniscus. And earlier surgeries when we used to do, we never used to stitch the meniscus. We used to just trim it. If it is torn here, we just have to trim this, and we go and trim here and remove the portion of the meniscus called meniscectomy or meniscus balancing. So this will reduce the pain, but it will lead to high chances of arthritis. So that's the reason now meniscus preservation is a very important part of surgery, and devices like this, all inside stitches, where we can put the small tube inside and we can stitch it without opening the knee, has come in force, and a lot of companies have come out with this, and there are very different ways we can stitch the meniscus and preserve the meniscus. This is the ACL, which is torn. I think there's a video associated with it. So you can just watch. So this is how we do a ligament surgery. So we clear the damaged ligament and make a tunnel in the bone. All this is done through an arthroscope without opening the knee. So we make two tunnels in the bone, the thigh bone and the leg bone. And we pass the graft. This is the graft which is taken. Fix it with a button. And then on the other side also, we either put a button or a screw. And that is how the ACL surgery is done. So other common condition for knee pain which everybody is aware is osteoarthritis. It's like when I have a hammer, everything looks like a nail. So people who are familiar with joint replacement will give joint replacement for osteoarthritis. Any osteoarthritis, finally they say is joint replacement. But that's not the case. And that's the highlight of this talk. So to know more about osteoarthritis, so this is how a normal knee looks. The cartilage is smooth all over. And this is how an arthritic knee looks. It's all broken down. So when you look at the X-ray, there is an equal space between the thigh bone and the leg bone. And there is no asymmetry in the joint. When you look at the arthritic knee, it's all totally reduced. There is bone sitting on the bone. So in this gap, which you see here as a gap, this is occupied by the cushion. The cushion is not seen on the X-ray, it's seen only on the MRI. So this gap, if it is proper, it means that the cushion is also in balance. There is no damage in the cushion. But if the gap is asymmetrical, then it means that some damage is there in the cushion, and then the layer of cartilage is also wearing out. And that's why when you put weight on your knee, there is reduction in space on the X-ray. So this is how an arthritic joint looks. So there's another video here. So this is an illustration. So just highlighting your cartilage, your ACL, whatever I said. That's the wear out of the cartilage once the arthritis happens. And that will irritate the surrounding nerves and the ligaments, and that's the way you get the pain. So there's a normal X-ray, there's the arthritic knee. So when you look inside the arthritic knee, that is when you put an arthroscope or camera inside the knee, This is how a normal knee looks. Everything is smooth, right from the cartilage. The cushion is also not torn. There is a smooth curve and bounce in the cushion, and the thigh bone and the leg bone, both the cartilage are fine. There is no loose bodies, and it's only occupied by a few joint fluid. And when the cartilage starts wearing out, it will look like this. It's like grass growing inside. So the smoothness is gone. The cartilage is all worn out. You'll have all fragmentation of the cartilage, and you can see that because of this, the pressure goes on the cushion also, and there is a tear in the cushion. The edges are all rough and irregular, and eventually, what happens as you continue walking on this, the cartilage is completely gone. You can see there's the bare bone. This is bone. That white layer is the cartilage. So there will be like a bone on bone, bone sitting on bone. That is the last stage. This is a grade 4 arthritis. And this stage is ready for joint replacement. So the grading according to the X-ray is done by Kelgan-Lawrence, the KL grading scale. So initially it's all smooth and symmetrical. Gap is all smooth. This is grade 1. The majority of the population are in grade 1. Then comes grade 2, where you see some reduction in space, and there is no osteophytes or anything. And grade 3 is you start seeing these edges, the rough edges here, the sharp edges. These are called osteophytes. And there is, when you see compare the reduction in joint space, the space is totally reducing. And finally, the space is totally reduced where the bone is sitting on the bone, and all the osteophytes are all becoming big, and they will irritate the collateral ligaments here, and then the joint also gets into a deformity mode. So different grades of arthritis.
Osteoarthritis is among the most common joint disorders and is characterized by joint pain due to wear and tear of the joint. This animation demonstrates the progression of the condition through 4 stages. Here's a healthy knee with healthy cartilage allowing for smooth motion. Grade 1 is partial damage of joint cartilage. Space narrowing. Grade 2 has moderate cartilage definite osteophytes or bone spurs and apparent joint space narrowing. Grade 3 has multiple osteophytes or bone spurs with definite joint space narrowing with apparent sclerosis of the bone. Grade 4 is the most severe. It's bone on bone with multiple large osteophytes or bone spurs with marked joint space narrowing and severe sclerosis.
So there are the different grades of osteoarthritis. So which grade you are in, I think you should be knowing by now. So how do you investigate? So investigation for osteoarthritis are usually clinically, where we examine the patient, clinically assess for pain, crepitous, joint space tenderness, deformities. We assess the walking capacity of the patient, and X-rays are usually taken. But the X-ray should be a standing X-ray. We always have to put weight on the joint and then assess how much the joint space is reduced. So normally when you may be sleeping, the weight is not going on the joint, so the joint space may appear normal. But the loss of joint space is only when you put weight. So when you weight bear on the joint, you will know exactly how much of space is reduced. So another way of assessing this, we ask the patient to bear weight on one leg. So weight bearing on one leg and assessing is also being done nowadays to see the extent of arthritis. So symptoms you should not ignore at all. So you may have some clicking or crackling sounds. You may have a mild swelling. You may have asymmetry. You may be limping. You may have stiffness. You may not be able to bend the knee, or the hip and the knee are the common. The hands are also common in rheumatoid arthritis. You may have some deformity in the alignment of your knee. You may have ability to walk or ability to bend, the ability to sit and get up will all reduce eventually. So these are all the signs and symptoms we should not ignore. So some of the risk factors you should know why you develop arthritis. So as I said, age, over the age of 50, common in both male and female. Male usually are obese by the time they are 50, and women usually after they cross 50 they tend to become obese. So obesity is one more thing which causes arthritis. A BMI of more than 25 is at a high risk. Other forms of risk factors are if you are already having increased uric acid or rheumatoid arthritis, or that can be a precursor and it can weaken your bones or your ligaments. And if you become obese on top of that, then you'll develop osteoarthritis on top of rheumatoid arthritis or gout, and both will lead to damage to your cartilage. Or if you have any knee injury and you're ignoring the knee injury and you're continuing your activity because of work pressure or other commitments, eventually it leads to arthritis. It could be a genetic disorder like a curved knee, or where the weight distribution is not going in the center, it's going on one side of the knee. And that can also lead to arthritis. Or if you're an habitual floor sitter, you sit on the floor, kneeling down, squatting. People who are associated with carpentry or goldsmiths or housewives, or people who do yoga and or too much of knee bending activities, they are prone to develop some small injuries to the knee which goes unnoticed and eventually leading to arthritis. Or if you are in a high impact sport or a physical activity or in heavy labor jobs, then you are also at risk of developing arthritis. So prevention is better than cure. So how do you do it? So you have to, when you look at this, it starts from 0 to the age of 90. This is the age. So when you look at initially at the younger age, you have to monitor, you have to look at your child to see if they have any abnormalities like hip problems. There'll be something called as congenital hip dislocation in children. So that has to be picked up early and treated. So otherwise that will lead to, an altered joint force traveling to the knee joint, and eventually as the child grows, they develop arthritis. And overweight or inactivity in children also should be monitored. Obesity is now climbing in children also. So they have to be going outdoor, playing, keeping their weight in check, and the junk foods and all that should be reduced. At the age of 10 to 20, we are into a lot of sports-related activities. And because that is like a career-orienting sport-related professional sports, people want to get into professional sports at this age. So minor injuries, they ignore, they don't tell, and they will limp or they will carry on playing because that will curtail their sports career. And that will develop some bony spurs developing, especially in the hip joints called cam deformity. And that can also cause problems. And eventually that can also go into all the weight-bearing joints like the hip, knee, and the foot, and cause different problems in different joints, leading to arthritis. And 20 to 30, that's another area where we are more focused on earning or working hard. And you should keep your muscles fit. You should always do some exercise, and you should not do overuse or neglect any knee injuries. You have to take immediate attention. And sports-related injuries, as I said, you should not ignore. You have to take a small break and get rid of that whatever is causing the pain and get back into sports. You have to prevent weight gain. That is usually women after 45. You have a hormonal imbalance. You may have going towards postmenopausal osteoporosis, and you have to be active. You should not gain weight, and that time that will lead to, because your bones are also getting softer, it will very high chances of developing arthritis after 45, 50. And you have to cut down on working too much or lifting heavy jobs or heavy weights after the age of 45, 50, and keep your muscles under check. You have to do some low impact exercises every day. You have to maintain it. And once you reach 60 plus or 70 plus, if you have already built your muscle here, you will maintain your muscle here. If you have not built your muscle here, if you have ignored everything, then eventually you will get what is called as a sarcopenia or weakness because of age, where you will not be able to do any activity, and even walking will become difficult. And by the time the arthritis would have set in, and because of arthritis, you'll have pain and muscle weakness, and arthritis will prevent you from doing any activity, and you will become sedentary, and again the weight will increase, and again the weight will fall on your joint, and it's like a circle, a never-ending circle you will get into, where the circle of pain has to be broken somehow. So these are the things which you can do to minimize or prevent reaching the stage of arthritis. So how to prevent? So strengthen your muscles, where once the muscles are strong, your load on your joint will be less, then that will lead to less wear and tear. And specific muscles have to be strengthened for each joint. It's not like one exercise for all. you have different joints in the body which can become arthritic, so everything has to be strengthened. So the AOS, or the American Academy of Orthopaedic Surgeons, they recommend some strengthening exercises. That is low impact aerobic exercise. Nowadays, aquatic exercises will help because they take the impact and will tone your muscles. Weight loss programs, weight loss programs is not just exercise, it's exercise and diet. So all these have to be done to prevent or go into a stage of arthritis. And other than this, what are the other non-surgical treatment? So we look into it. So one is medicines. You have tablets, that is painkillers or NSAIDs, different painkillers are there. So they are to be taken for a short period. So that will reduce the inflammation and reduce your symptoms. And once the symptoms reduce, you can take some anti-edema tablets to reduce the swelling. So tablets will be the first line of treatment. Then will be eyes. And later on, we can give some intraarticular injections, multiple intraarticular injections, which have come into force now. So common are the corticosteroids, which everywhere they have been giving corticosteroids, and they are known to work for some period. But repeated use of corticosteroids will cause some problems. It leads to some bone softening. It can lead to infection. And if you are planning on any surgery later, the chances are very high of you getting infection back. So corticosteroids maybe 1 or 2 times is okay. So to prevent the side effects of corticosteroids, there are others like hyaluronic acid, which has come. Initially, it was hyaluronic acid where we used to give 5 injections weekly once. Then the generation started building. Then the new generation of injections are there where we give once a year, and it can last for up to 6 months to 18 months. And usually it is given in grade 2 to 3 arthritis. It doesn't work in advanced arthritis. So hyaluronic acid is relatively very safe, no side effects at all. The earlier grades used to be from a chick embryo, so there were some allergies to the hyaluronic acid. But now 4th or 5th generation or 6th generation injections have come, which is based on human DNA RNA based. Then there are also highly cross-linked hyaluronic acid, so that the longevity of the injection has to increase. So nowadays, the highly cross-linked hyaluronic acid has worked for many people for more than 18 months also, to 2 to 5 years also. There are some patients who claim that they have found relief. They come back for a second dose of injection. Even though we don't advise, they do usually come back and ask for it. Then there is something called as the PRP. There is a platelet-rich plasma, or the BMAC or bone marrow aspiration, and the cells which we inject into the joint. They are also relatively safe. So we take blood or we take bone marrow, and we centrifuge it and take the plasma. And plasma will be injected in the knee, just like how you can see in this picture. So it's given under local anesthesia. The injection will be given. So these are known to regenerate cells. That's the reason they have come into existence. So PRP or bone marrow cells, they are known to regenerate your damaged cartilage, and they give an opportunity for whatever the existing cells or the dormant cells which are there in the body to produce more cells and cover up the defect. So that has also been given for arthritis. And we have this offloading knee braces. They are something which is non-invasive and not like a normal knee brace. So these knee braces are totally working in a way where they take the load off your damaged area, like this. This is the damaged area. So once you put the brace, they offload that area. The weight distribution is offloaded. So the weight is not going in the damaged area, and that will relieve the pain. And then you can do the exercise. Then you can do strengthening of your muscles, and you can reduce your weight, and that will maintain this whatever stage you're in for a long time. I think there's a talk on offloading knee brace later. And as I said, the PRP or the stem cell therapy. So this is how it looks. We take blood, maybe 10 cc of blood, and then when we centrifuge, we get all these layers of tissue separation. So this is the poor plasma, this is the rich plasma, and this is the cells which are at the bottom. So we take this rich plasma, and then we inject it into the joint. It's just a 10 to 15 minute procedure, and the patient can walk immediately. So this is a way it is given. So platelet-rich plasma or hyaluronic acid, it's just an outpatient procedure, but they're a little expensive. And when you look at hyaluronic acid, that is the injection, the lubricant, versus the PRP. So both are in the outpatient treatment. They're less time consuming. The patient can be immediately mobilized. There's no bed rest required for both the injections. And the hyaluronic acid is just a lubricant. It maintains the viscosity of the joint so that the friction is not there between the bony surfaces. And then it helps to regenerate some synovial fluid. So that is known to maintain the viscosity, and that is going to last for 6 months to 18 months. And PRP, it doesn't do any lubrication. It is more of a regeneration. It is going to regenerate your damaged cells. It's going to reduce pain to a certain extent, and it can be repeated any number of times. So finally, we come to joint replacement. So total knee replacement is the end game. So once your joint is totally worn out, then we have to replace it. The joint replacement is not that you're going to remove the knee or something. It's only the damaged lining which is taken off, and the metal lining is given, and this cartilage on the cushion is taken off, and plastic is kept, high density polyethylene, and then the lower surface is removed, and we put a metal plate here. So the joint is now between the two metal surface and a plastic. So different research has gone in this joint replacement, and different materials are also there. So nowadays we have cobalt chrome alloy with the oxynium coating, so increase the longevity. And this polyethylene also, we have from a cross-linked to a highly cross-linked to now oxidized highly cross-linked polyethylene. Every research is to improve the longevity of the joint replacement. If you have only a small portion of the cartilage which is damaged, now that can be treated arthroscopically. That is a keyhole surgery. This is usually in young patients or in grade 2, grade 3 arthritis. There only some portion of the cartilage, a focal defect will be there. Now that can be treated by a keyhole surgery where we just put a camera inside and just clean the damaged area and make some holes in the bone so it generates blood and the clot forms over there, and that is replaced by a fibrocartilage. This is called microdrilling procedure. Or we can, if the defect is a little bigger, like 2 to 4 mm, then what we do through a camera only, we take the cartilage which is from the non-weight bearing zone, so where the weight of the body doesn't go. So we remove the cartilage plugs from there and then pack it into those defects, and that is called as mosaicplasty. Then there is a what is called as an ACI. Now suppose the cartilage is a little bigger, like 4 to 5 mm, then we can't keep plugging it. So we take this cartilage cells from the non-weight bearing zone, and initially we used to send it to a lab, and in the second sitting we again come back and take the tissue from the lab where they grow the cartilage, and then we pack it there and fix it with a fibrin glue. Of late there's another procedure called autocart, where we take the cartilage from the non-weight bearing zone, and that is collected in a filter, and immediately we take PRP and mix it with those cartilage cells, and in the same sitting we just pack it and fix it into the damaged area, and then we keep the patient on a minimal weight bearing or non-weight bearing, and that is known to fill up these focal defects or only small defects in the joint. So if the patient is having only one full compartment of joint damage, then we can do what is called as a itibial osteotomy or a unicondylar knee replacement. So that is another surgery where we don't do a total knee replacement, where we replace only the area of the cartilage which is damaged, or you take only this one compartment. If you take this as one compartment, this is the second compartment, and the patella as the third compartment, we only take the tissues or the surface of this one compartment and replace. That's called as a unicondylar knee replacement. Later on, when the other compartment also gets affected, then patients can be converted to a total knee. The advantage of a uni knee is it's less morbid. So the pain is less, the surgery time is less, your other cartilage, everything is retained, and that will also last around 10-15 years if we pick it up early. But the indication for this is no other joint should be involved. Only this joint should be involved. Or if even in grade 2, if there's, when you see under arthroscopy and see only the cartilage or the meniscus is damaged, we can repair the meniscus and we can do what is called as an itibial osteotomy. Itibial osteotomy is we take a triangle, a wedge of bone from here, and we open the joint so that whichever area is in contact open up, and we just fix it with the plate. That is called as an itibial osteotomy. And then finally, if none of these works, even itibial osteotomy has worked 10-15 years. This is for patients who want to remain active, want to do all activities, even with the mild arthritis, where we can do an itibial osteotomy and patient can get back to all form of sporting activities. But when you do a joint replacement, then your sporting activities gets reduced. It will be a low impact exercise, walking, brisk walking, maybe golf or swimming or something like that. So, and total knee replacement is also very common nowadays. It's not like a big surgery. And another toy which has come now is robotic total knee replacement, which most of you should be aware. Robotic total knee replacement is also more accurate than the conventional knee replacement. That's what the study says, but it is more time consuming. It takes another 30-40 minutes extra. And the difference between a conventional total knee replacement and robotic knee replacement is a robot will align the implants to your body. But as in a conventional knee replacement, we have a fixed mechanical angle which we have to follow, and we just fix the implants to the fixed mechanical degree based on the available jigs that we have. But in robot, we do what's called as a kinematic alignment, where every person's alignment will be different, slightly different, which the robot will assess and give us the degree, and that will be placed accordingly. So there will be less steps in a robotic knee replacement, where we will not pass any rod inside, we will not pull and spread the tissues much. So the pain factor also is less for the patient. That's the feedback. But still under research and long-term results are yet to be awaited. So that's it for arthritis, the different treatment modalities, including knee replacement, which is the hammer with the nail, and other forms of treatment, which will be tailor-made to the patient after we see the patient, after we assess the symptoms, the body mass index, the bone mineral density, and see the strength of the bone, and assess each muscles, and then a tailor-made treatment can be given to the patient. And based on what stage you are in and your weight-bearing X-ray, the different treatment modalities can be given to you. So, thank you.
So thank you very much, doctor, for your wonderful, and you are explained in detail about various pathologies, what are the various reasons for the knee pain, and the alternative treatment options. It is not only the knee replacement. There are various multiple modalities are currently available. For example, the itibial osteotomy, even a PRPs, and so many aspects are there. New techniques are available. You are explained in detail very well. Thank you very much, doctor. Before we are going to jump into the question and answer session, with your kind permission, I would like to go for a small presentation on braces, because you are shown braces also one of the option as a non-surgical treatment option. So most of the people, they aware brace actually, but what is the new braces are available, the advanced innovative braces are available for osteoarthritis. With your kind permission, I would like to go for that.
Okay.
Yeah. Subhash. My screen is visible, I think. Naveen, please confirm. Kishore, visible? Screen is visible? Just you pinned up. Yes. 1 minute. Just a minute. So thank you very much. See, now we are going to see what is the role of braces in osteoarthritis as a conservative treatment, because you know that conservative is nothing but without the surgical procedure. And in that, what is the role of braces actually? Braces, everybody knows what is mean by that. Brace is nothing but actually is an external device. It is not going to be implanted inside the body. Okay, so brace is an external device. There are different braces are available in the market. So you should know that which brace which really suits for your need actually. So before you are going to select a brace, you should consult the doctor. That is always better. Without any consultation from the orthopedic surgeon, buying a brace and wearing is not that much advisable, and it is not going to give a proper results for your knee pain. Okay. So there are multiple for a post-operative, for a preventive prophylactic, for osteoarthritis, ligament braces. So many braces are available in the market. Like especially when it comes to the osteoarthritis braces, you can see that there are two braces. You can able to see that now. One is on the left side. You can see that as a black color one is a off-loading brace. On the other side, you can see a white one is the normal compression sleeve, which is in the pharmacies also now. You can able to see that most of the people, they try to wear this actually. They want to buy and they will try to use this for osteoarthritis. But how these braces are going to be effective for osteoarthritis, we'll discuss now. So off-loading brace is nothing but actually the name itself. Sometimes it is called off-loader or unloader. See, because of the weight only, because of our body weight, it goes to the particular compartment, whether it is inside the knee joint or outside. Okay, the damage will start. Actually, osteoarthritis, as doctor also explained in his presentation, is a wear and tear disease. Okay, once the weight goes to that particular compartment, the wear and tear will start. So to reduce the wear and tear, to stop the wear and tear, we need to shift the load. We have to avoid the load goes to the particular compartment. So the off-loading braces having that particular mechanism which shift the load from the affected to the unaffected area, that is why it is called off-loader or unloader braces. So you can able to see the difference between these two. In a compression sleeve or a normal kneecap, that is a common nomenclature, they are using that. There is no such mechanism or not available actually. You can see that there is no mechanism. Actually, it is a compression sleeve. It gives compression. Sometimes compression also gives the relief of pain. But actually, whether it is going to increase the joint space, that is what it is not going to do that. So offloading braces, if you see that, this is our Breck freestyle offloading braces. You see there is a dial is available on the outer side, okay, which pushes the joint and open the joint space. See that before brace, you can see there is a joint reduction. You can see that now after brace, you can see visibly there is a good enough space. So once the space is increased, automatically what happens? The pain will stop or reduce actually. And additionally, the damage will not happen further. See, whatever the damage happened on the articular cartilage stops at that particular stage. Whether it is a 40% damage is there, it is going to be at the 40. It is not going to continue behind 40% damage. Because this is osteoarthritis is a wear and tear disease. So it is the brace, offloading braces stops the wear and tear, and additionally it stops the pain. That is what the role of offloading braces. You can see the dials actually. In this video, I'll show you how it works also. You can see the
braces gently apply pressure to the unaffected side to align the knee, taking pressure off of the affected side of the knee. The higher the number on the thumb wheel, the greater the amount of force on the knee. These before and after x-rays show how Breck's Freestyle OA brace affects the knee.
I think hope you saw that how the joint space, you see that before brace, after brace, how it is increasing. It is very simple that the offloading mechanisms are happening with the help of thumb wheel dial. You can see that now.
Before and after x-rays, thumb wheel.
This is very simple. These type of mechanisms are not available with the compression sleeves. So selecting the right brace after the consultation with the orthopedic surgeon is always better actually. Okay. So what is the benefit of this braces is very easy to apply. and you can just, it is just like a wraparound design, no need to have a very complicated thing. And it helps to reduce the compression, also reduces the swelling also. Very comfortably you can use the dials. Suppose while you are walking, if you are feeling a pain, you can increase the dial or you can reduce the dial. It is very easy for use. You can see the real-time patients after they have started using the brace. You can see visibly the X-rays, how it increases the joint space. And what is the benefit of freestyle knee brace? As I informed already, as I mentioned already, the pain is reduced or stopped, and you can get a confident while you are walking. Your knee feels support actually, and it increases your quality of life. You can able to do your day-to-day activities without any pain. So that is what the benefit of this freestyle OA. More than 6,000 patients in India, they started using this brace. And if you want to try in Bangalore, free trial also we are ready to give. After this session, we are going to share the forms in the WhatsApp group. You can, if anybody wants to try this brace, we are ready to give the 100% free trial. So another next generation braces also now available, especially for higher BMI patient, because it is a powerful offloading. It's a double upright braces, but here you should have this type of Allen keys to go for that. You can see the gap, how it increases. It pushes the joint from opposite side. You can see the patient feedback, how they are walking before and after. You see that before that, without brace, you can see that she is putting the support. She is trying to put the support, but after the brace, she is not looking for a support. She started bending and coming down easily. You can see that how she is walking. See, she has not walked more than 4 years. She used to walk within 1 or 2 minutes only inside the house only. She afraid to go outside actually because of the knee pain. You can see that now how she started walking confidently, and you see that how fast also she started walking. So this is the benefit of this type of braces. You can see this patient. This is a very severe condition. Even in the severe condition, this braces also will help. So selecting the right brace also is more important. So always consult the doctor to select the site. Thank you very much for your patience to listen this. Thank you very much, doctor, for giving the opportunity to present this. Thank you very much, doctor. Yeah. Just a minute. Thank you very much, doctor. With that, now we'll move to the question and answer session. Just a minute, sir. If there is any message, those who want to talk to doctor, please raise your hands before that. First, Suchita, you are asked, you raise your hand, please. If you have any question, please talk to the doctor right now. Unmute and talk.
Hello, doctor. Hello, am I audible?
Yeah, you're audible, Ari.
Yeah, doctor, I have a question. Yes. Literally, I'm facing some chondromalacia patella. Okay. And I'm doing some gym activities too. How to manage both?
The chondromalacia patella will be mostly because of your lifestyle.
Yeah.
So professionally, what you're doing, if you are doing a sitting job or if you are having knee bending activities, then you have to stop or you have to take breaks between your work. In between your work, you have to stretch out yourself. You have to do some stretching exercise.
Yeah,
And, you have to do some physiotherapy where you strengthen your inner thigh muscles.
Yeah.
And you have to minimize climbing stairs. You have to minimize Indian toilets. So, and then you have to meet a good physiotherapist and some inner thigh, that is vastus medialis obliquus strengthening exercises can be done. But if you are also having chondromalacia because of some mechanical factors like a maltracking kneecap, then you have to do one skyline X-ray of your knee and see whether your tracking of your kneecap is normal. And if your tracking is abnormal, then there will be high chances that the grades will be around 2 to 3. Then you have to confirm that on an MRI. And if your cartilage is severely worn out, then based on that, either you have to realign your kneecap and bring it to the center, or you can do a keyhole surgery and get your stage back to grade 2 or grade 3. From grade 3, you can come to grade 2, where we can clean all the damaged areas. And then you have to take some cartilage supplements, and then continue to do the exercise and modify your lifestyle for at least 3 to 6 months, and then get back to sports or whatever activity you want to do.
Yeah, okay. Recently I'm performing some physiotherapy, and recently I took MRI, CT, everything I took. Okay. And currently I'm looking like I wanna do gym activities and as well as to play football too.
No, it depends on what is your MRI finding. If it's an early grade chondromalacia, then definitely you can get back to sports, provided your muscle strength is good and you build your muscle strength. So till you build your muscle strength, you avoid activities which involves knee bending. You avoid Indian toilets. You avoid stairs. You avoid knee bending yoga, or sitting and down and praying, or sitting down and having food. So all those activities have to be avoided. You have to concentrate only on preventing further damage to that kneecap bone and the cartilage. And whatever stage you are in, you have to maintain that stage and build your muscle around it. You can take cartilage supplements, or you can take the hyaluronic acid or a PRP injection, which will also help to regenerate your cartilage to a certain extent. And then afterwards, you can assess the muscle strength with the physiotherapist and get a sports-related training, and then get back to football.
Yeah, thank you, doctor. Is it okay to connect with you personally so that I can share my reports and you can suggest me some?
Yes, you can.
Sorry, doctor.
So they will share the details with you, so you can just get in contact.
Yeah, okay, doctor. Thank you.
We are going to share doctor clinic address as well as how to get the appointment and all contact details. We are going to share it in the WhatsApp group. No worries. Okay. Thank you. Thank you.
Thank you.
Any other questions to doctor? Anybody wants to talk to doctor? 1 minute, sir. Suchita, you are raised your hand. Even you can ask. You can talk to doctor in Kannada also. No issue. You can ask. You can start. I think there is no response. Vinny, Mr. Vinny.
Hi, doctor. Good evening. I am Binny, and I have got plantar fasciitis.
Okay.
And I want to know what precaution should be taken to cure that. It is since last 3 months I have this problem. It is reducing sometimes, but it is coming and going.
So you have early morning pain when you wake up from the bed and you keep your foot down.
Yeah, that also it has reduced quite a bit. But after doing morning walk, I will be doing some 8,000 steps, and later I will be getting pain on and off. It is not always.
Okay.
But
you work, or you do some standing activities?
It is. It's mostly. Yeah. Okay. I should not stand.
No.
It's a household work.
Are you in any profession which involves standing activity?
No. Now I am retired.
Okay.
Retired.
Arthritis is a lifestyle problem. It commonly happens when you stand for long. So suppose you take a model of a foot. So there is something called as the fascia. It's called plantar fascia, which goes from the toes all the way to the heel bone. So if you are standing for long, or if you have used a new footwear, or if you have walked barefoot or played somewhere, or if your weight is so much that one side of your shoe is wearing out, it indicates that there's a lot of force going on to your plantar fascia. It means that the fascia is not getting stretched, so it's unable to distribute your weight. So for this, all you have to do is minimize standing. That will be a modification of your lifestyle. Even if you have to stand and work at home, you may have to take break. You have to lean some on the stool or somewhere and stand, so that the entire weight is not going on the foot. And you have to use a MCR footwear or a microcellular rubber footwear, which is like a soft rubber footwear, distributes the weight in the foot. You should avoid barefoot walking. You should reduce your weight. You should do some stretching exercises of the foot. So as soon as you wake up in the morning, you have to stand on your toes. So standing on your toes will stretch the fascia. Walk on
For
your
how
toes.
long?
Walk on your
For how
toes.
long?
Yeah.
For how long I should stand on the toes?
Just 30 seconds. 30 seconds. So half a minute. Just try to walk on your toes. That will stretch your muscles. Then keep the heel down. Before going to bed also you can do the same activity, which will stretch the muscles. And at home you can take a cork ball or a leather ball, put it on the floor and roll your heel over that. Stand and roll your heel. So that
It is only heel. It is only heel or full.
The entire thing you can roll. The plantar fascia goes all the way. So you have to stretch the entire fascia. Or you can take a round bottle, plastic bottle, fill it with water, put it in the freezer, and you can keep it on the floor and roll your heel over that. So all these forms of exercise will stretch your plantar fascia. And in addition also, Breg also has some orthotic devices, which are night splints also for plantar fascia. You can get in touch with them. You can use those splints and you can continue to do your activities. And you can also take some supplements like collagen type 1, which will help in helping healing of your plantar fascia. In spite of all this, if your plantar fascia is not coming now, you can take a course of physiotherapy where they give you some ultrasonic massage, interferential therapy and iontoporosis, which will also help in relieving the inflammation of your foot. They will also give you some shockwave diathermy, extracorporeal shockwave diathermy, which will also help in reducing the inflammation. In spite of that, if you're still having the plantar fasciitis, we can give the PRP injection, where we inject it just here. So it's under local anesthesia. The PRP injection is known to give a lot of good results for plantar fasciitis. People who have taken PRP injections, they have not come back actually. They are doing very well. Even a single dose, a lot of people have found tremendous relief. Long distance marathon runners who come for the same problem, I've given them a lot of injections, marathon runners. So they're all feedback is they're doing good. So do all this, maybe you'll get better.
Yeah. Thank you, doctor. I was working with the Zydus company and I was meeting you in Horsemet.
Okay.
Okay. Thank you, doctor. Thank you very much.
Well, thank you. Thank you, madam. This is Anusha Subramanian. You can unmute and talk now. You are raised your hand. If you have any question, please go ahead now.
Am I audible, doctor?
Yeah, ma'am, you are audible.
Hi, doctor. I'm your regular patient, Anusha.
Yes, ma'am.
And just 2 hours back, I've come from Bengaluru to Salem to drop my mom. My mom was in Bengaluru with me for a week.
Okay.
Actually, for the cold climate in Bengaluru, I developed severe pain due to varicose veins.
Okay.
So I didn't have time to wear my socks also.
Okay.
Are there any braces or ointments for varicose veins, doctor?
Varicose veins, there is no ointment as anything. Only for thrombophlebitis, we give the thrombophobe ointment. Stockings are the only.
But it's really painful.
Stockings are the only solution. There are some medicines you can take which will help in early grade varicose veins, which will help in improving their blood flow. And the other way is to just keep doing your tiptoe exercises.
Yeah, I do that regularly, doctor.
That will increase your blood flow. You have to avoid standing, to keep your foot elevated. So these are the initial treatment for varicose veins. The common is the stockings. You should not stop using it. And you have to avoid standing for long. And the tiptoe exercises. And there are some tablets which you can take, like the tablets which are not having any side effects, but will improve your blood flow. And early grade varicose can be managed with those tablets.
No, this varicose veins I've been having for a long time, doctor. For nearly 15 years. It's not at all going. It's only in my left leg. So I don't know.
So you have to do a Doppler study. Find out how much of veins are not competent. That is not working correctly. And then you can either go for a stripping, that's a varicose vein stripping surgery. That is also a simple surgery, but it will give you a
It will be really painful, no, doctor? So, like, I just want to go in for tablets.
It's not painful. It's done under anesthesia. Vascular surgeons usually do it. And
Okay.
it has a very good relief. You can try.
Okay, doctor. Yeah. Could you please message me the tablets later on? I'll just get it from the pharmacy. Okay. Thank you so much, doctor. Bye.
Thank you very much, Anusha. You have any other questions? Anybody wants to doctor now? Please raise your hand, or you can ask directly now. Okay. I think there is no question. Doctor, one more question in the chat box actually. Would physiotherapy or any other exercise which really help for away osteoarthritis?
Yeah, that's a custom-made exercise where you have to build your quadriceps and inner thigh muscles. So initially, when you have pain, you can go for a course of ultrasound and interferential therapy, the short period, and then you have to start building your muscles. That is the quadriceps and hamstrings, and your IT band stretches, which you can't do by yourself. You have to go to a physiotherapist. You have to learn those exercises, and then you have to do it. And if you are in early grade arthritis, it will definitely help. And you have to continue to do the exercise so that your muscles remain strong. And every day, if you spend 5 to 10 minutes or 15 minutes and learn the exercise well and do it regularly and step up the exercise with gradual lifting of weights and resistance bands, which will strengthen your quads and hamstrings and your inner thigh. And that will go in a long way in you going towards the advanced grade of arthritis.
Thank you, doctor. One more person raised. Mrs. Preeti Patil, you want to talk to doctor now? Please unmute and talk. Ma'am, your voice is not clear. Sir, she texted me actually.
Okay.
Grade 3, is surgery a must?
Grade 3 surgery is not a must, but we should know what is your walking capacity. If your walking capacity is less than like within the house only, you're walking only from the bed to the kitchen to the bathroom and back to the bed, you're not able to go out, you're not able to walk less than 50 steps or anything, then surgery is a must. But if your walking capacity is somewhere around half kilometer to 1 kilometer, I think surgery is still can wait. You can start your rehab program, you can start physiotherapy, build your muscles. You can go with the intraarticular injection, there's a hyaluronic acid injection or a PRP or both together. And you can see that you will have a good amount of pain relief. And once the pain is relieved, you can, that is when the injections will work from within the joint. Then you have to do exercise and stabilize your muscles. You have to lose weight. You have to modify your lifestyle. You have to avoid knee bending activities, which will put more stress on the knee. And you have to wear those knee braces, which will also offload the weight-bearing region. And this helps in a long way in maintaining your arthritis at grade 3.
Thank you very much, doctor. As you rightly pointed out, first we need to understand their current physical activity, how they are actively doing their work. See, most of on behalf of you, a small request to the participants. Most of the time, people are looking. They are thinking that without physical examination, they want the solution sometimes. Because my suggestion will be always take the physical examination is more important when it comes to the osteoarthritis, especially for ortho problems. By talking to the doctor virtually and asking solutions, sometimes also not good actually. Okay, so that is what my request. And one more question, doctor, actually, just a minute, sir. Ma'am, actually, we will share the detail. Sir, just now that Preeti Patil, she wants to meet you personally. So sure. We will share the contact details, madam, don't worry. Anybody wants to talk to doctor now? You have any question? Yeah, Akila, Mrs. Akila Krishnamurthy, you can talk to the doctor now. Unmute and talk now.
Good evening, doctor. I am Akila Krishnamurthy. I'm 66 years old and I'm having grade 4 arthritis detected. So surgery was suggested, but I'm not very much inclined to go in for total knee replacement. I'm taking some physiotherapy now, doing exercises at home. I'm able to walk for 10 minutes, but I'm not able to climb upstairs without support and all. Is there any that injections you spoke about? Will it help me? Can I take them? No.
Yeah, injections can be taken, but because you're already in the last stage is
grade 4.
Yeah, somewhat like this. So all your bones are rough and the cartilage is worn out. So there is bone on bone. That is grade 4. But in spite of being in grade 4, you're already walking 10 minutes. That's a good thing. So your muscles should be a little bit strong. So
I'm doing physiotherapy, taking physiotherapy and doing exercises, strengthening and stretching exercises.
And your body mass index also should not be very heavy. So I think the body weight is maintained. So you can go for the injection, but before that, we would like to see the X-ray once to see how much is there a little bit of gap even left.
Okay.
So the injection will only lubricate your joint. It will increase your walking capacity from 10 minutes to maybe another 10 minutes.
Okay.
It will also help you to live a better life than what you are now living.
Yes.
But the longevity of the injection will not be very high because you have already reached the grade 4. It might work for you maybe 6 months or 8 months. In very good cases, even a year it might work. We don't know. So if you are able to take the injection and if you are able to do those exercise and if you take the offloader brace also, so you will be covered in all ways. So from mechanically and internally, and you're also putting your effort and your muscles are strong, you're becoming strong. So you can manage without surgery. But
for how long, Dr.
Grade 4, we cannot say. You will reach a period when your 10 minutes will become only 1 or 2 minutes. Now that will be a clue for you that you have to go for joint replacement. You can also use a cane at home, a walking stick at home, if you don't want to use outside. That will also offload your knee joint and will also help you to walk better.
Okay, sir. Okay, so what is is there any right age to go for the surgery? Like some people say the earlier the better, some people say the later the better because the longevity of the total knee replacement that will work for more years and all. So what is there any such thing as the right age to go for the surgery, total knee replacement and all?
The right age usually is above 50 is usually better. But there are exceptions. We have done joint replacement for 40 to 44-year-old people with not osteoarthritis, but rheumatoid arthritis, then leading on to osteoarthritis, where their walking capacity is 0, where they walk only within the house. But usually the common protocol is we delay as much as possible. Because we are active till 60 or 65. And beyond that, the activity reduces or drops. So if you do joint replacement at the age of 50 and you are very active, and if it works for 15 to 20 years, by 65 you will again start feeling the pain and again you will need a revision surgery. So a little bit if you can push your age for arthritis for another 4-5 years, then one surgery will last 10 to 20 years. And then that will make sense and one surgery will work for the rest of your span. So that's the reason all these braces, these injections have all come in. And they are also doing a good job. So they are also helping patients to continue their lifestyle with minimal intervention.
Okay. Thank you so much. So the braces will help me. Can I go for braces also?
Yeah, braces will help you and they are also giving you a trial. You should try it.
Okay, sir.
Okay.
Thank you very much. Thank you very much.
Thank you, madam. We are going to share the link also in the group. Maybe if you want to try, we can arrange for that. That is not an issue. We will arrange it in Bangalore.
Thank you, sir.
Yeah. Mrs. Akila Krishnamurthy, please unmute and talk now.
I just spoke, sir. I just spoke.
Sure. Thank you. Any questions to doctor now?
Yes.
Yes.
I'm Kamala Jagdish, sir.
Yeah.
Yes.
ನನಗೆ ಕಾಲು ಲೆಫ್ಟ್ ಲೆಗ್ ತುಂಬಾ ಪೇನ್ ಇದೆ, ದೆನ್ ರೈಟ್ ಸೈಡ್ ಲೋವರ್ ಬ್ಯಾಕ್ ತುಂಬಾ ಪೇನ್ ಇದೆ. ಒಂದು 10-15 ಮಿನಿಟ್ಸ್ ವಾಕ್ ಮಾಡಕ್ಕಾಗತ್ತೆ. ಸಮ್ ಸಪ್ಲಿಮೆಂಟ್ಸ್ ತಗೊಂಡ್ರೆ ಸ್ವಲ್ಪ ರಿಲೀಫ್ ಕೊಡುತ್ತೆ. ಅದು ರೆಗ್ಯುಲರ್ ಆಗಿ ತಗೋಬಹುದಾ ಅಂತ ಗೊತ್ತಾಗ್ಲಿಲ್ಲ.
ಸಪ್ಲಿಮೆಂಟ್ಸ್ ತಗೊಬಹುದು. ಸಪ್ಲಿಮೆಂಟ್ಸ್ ಅದು ಒಂದು ವಿಟಮಿನ್ ತರ ಬರುತ್ತೆ, ಅದ್ರಲ್ಲಿ ಏನು ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಇರಲ್ಲ. ಸಪ್ಲಿಮೆಂಟ್ಸ್ ನೀವು ತಗೊಬಹುದು, ಅದೇನು ತೊಂದರೆ ಇಲ್ಲ. 1 ವರ್ಷ ಬೇಕಾದ್ರೂ ತಗೊಬಹುದು, ಅದ್ರಲ್ಲಿ ಏನು ತೊಂದರೆ ಆಗಲ್ಲ. ಬಟ್ ಪೇನ್ ಕಿಲ್ಲರ್ಸ್ ಅಥವಾ ನೋವಿನ ಮಾತ್ರೆ ಏನಾದ್ರು ಇದ್ರೆ ಅದು ಸ್ವಲ್ಪ ನೀವು ಒಂದ್ ಸ್ವಲ್ಪ ದಿನ ತಗೊಳ್ಳಿ, ಆಮೇಲೆ ನೋವು ವಿಪರೀತ ಆದಾಗ ಮಾತ್ರ ತಗೊಳ್ಳಿ. ಮತ್ತೆ ನೀವು ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡ್ಬೇಕು. ನೀವು
ಯೋಗ ಕ್ಲಾಸಸ್ ಅಟೆಂಡ್ ಮಾಡ್ತಿದ್ದೀನಿ.
ಯೋಗ ಕ್ಲಾಸ್ ಮೊಣಕಾಲ್ಗೆ ಅಷ್ಟು ಹೆಲ್ಪ್ ಆಗೋದಿಲ್ಲ. ನಿಮ್ಗೆ ಸೊಂಟ ನೋವಿಗೆ ಹೆಲ್ಪ್ ಆಗುತ್ತೆ, ಬಟ್ ಮೊಣಕಾಲ್ಗೆ ಮಂಡಿ ಮಡಚಿ ಯೋಗ ಮಾಡಿದ್ರೆ ಸ್ವಲ್ಪ ಹಾನಿಕರನೇ. ಸೊ ಮಂಡಿ ಮಡಚಿ ಯೋಗ ಮಾಡೋದನ್ನ ನಿಲ್ಲಿಸಿ, ಮಂಡಿ ಮಡಚದೆ ಯೋಗ ಬೇಕಾದ್ರೆ ಮಾಡಿ. ಎಕ್ಸರ್ಸೈಸ್ ಅದು ಫಿಸಿಯೋಥೆರಪಿ, ಯಾರಾದ್ರೂ ಫಿಸಿಯೋಥೆರಪಿಸ್ಟ್ ನ ಮೀಟ್ ಮಾಡಿ ಅವ್ರ ಮೊಣಕಾಲ್ ಎಕ್ಸರ್ಸೈಸ್ ಹೇಳ್ಕೊಡ್ತಾರೆ, ಅದನ್ನ ದಿನನಿತ್ಯ ಮಾಡಿ, ಲೈಫ್ ಲಾಂಗ್ ಮಾಡಿ. ದಿನಕ್ಕೆ 1 ಸಲ ಅಥವಾ 2 ಸಲ ಆದ್ರೂ ಮಾಡಿ. ನಿಮಗೆ ಅದು ಈಗಿರೋ ಕಂಡೀಷನ್ಗಿಂತ ಇನ್ನೂ ಸ್ವಲ್ಪ ಬೆಟರ್ ಆಗ್ತೀರಾ.
ಫರ್ದರ್ ಪೇನ್ ಗೇನ್ ಮಾಡ್ಬೇಕು, ತುಂಬಾ ಪೇನ್ ಇರುತ್ತೆ ಡಾಕ್ಟರ್. ಅದು ರೆಸ್ಟ್ ತಗೊಂಡ್ರೆ, ಐ ಆಮ್ 75 years old, ರೆಸ್ಟ್ ತಗೊಂಡ್ರೆ ಐ ಬಿ ಓಕೆ, ಇಲ್ಲ ಅಂದ್ರೆ ತುಂಬಾನೇ ನೋವಿರುತ್ತೆ.
ಇದು 75 ಅಂತೀರಾ, ನಿಮ್ಗೆ ಅದು ನಿಮ್ದು ಬೋನ್ ಮಿನರಲ್ ಡೆನ್ಸಿಟಿ ಒಂದ್ಸಲ ಚೆಕ್ ಮಾಡಿಸಿ. ಬೋನ್ ಸ್ವಲ್ಪ ಸಾಫ್ಟ್ ಆಗಕ್ ಶುರು ಆಗುತ್ತೆ ಈ ಏಜ್ಗೆ. ಸೊ ನಿಮ್ದು ಭಾರನೇ ನಿಮ್ಗೆ ಜಾಸ್ತಿ ಆಗುತ್ತೆ. ಸೊ ಬೋನ್ ಸಾಫ್ಟ್ ಆದ್ರಿಂದ ಅದು ಆಸ್ಟಿಯೋಪೊರೋಸಿಸ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಸೆನಲ್ ಆಸ್ಟಿಯೋಪೊರೋಸಿಸ್, ಪೋಸ್ಟ್ ಮೆನೋಪಾಸಲ್ ಆಸ್ಟಿಯೋಪೊರೋಸಿಸ್. ಅದರಿಂದನೂ ನಿಮ್ಗೆ ಬೋನ್ ಪೇನ್ ಬರುತ್ತೆ. ಸೊ ಇದು ನಿಮ್ಗೆ ಬ್ಯಾಕ್ ಪೇನ್ ಮತ್ತೆ ಮೊಣಕಾಲ್ ನೋವು ಅಂತ ಅನ್ಕೊಂಡಿರ್ತೀರಾ, ಬಟ್ ಇದು ನಿಮ್ಗೆ ಬೋನ್ ವೀಕ್ನೆಸ್, ಬೋನ್ಸ್ ಕಣಜೀಕರಣ ಕಡಿಮೆ ಆಗೋದ್ರಿಂದ ನಿಮ್ಗೆ ಈ ತೊಂದರೆ ಬರ್ತಾ ಇರುತ್ತೆ. ಸೊ ಆದ್ರಿಂದ ಒಂದ್ಸರಿ ಕ್ಯಾಲ್ಸಿಯಂ ತಗೊಳ್ಳಿ. ಕ್ಯಾಲ್ಸಿಯಂ ತಗೊಂಡು ಸ್ವಲ್ಪ ಬೋನ್ ಸ್ಟ್ರಾಂಗ್ ಮಾಡ್ಕೊಳ್ಳಿ. ವಿಟಮಿನ್ ಡಿ ತಗೊಳ್ಳಿ. ಸ್ವಲ್ಪ ಬಿಸಿಲಲ್ಲಿ ಸ್ವಲ್ಪ ವಾಕ್ ಮಾಡಿ, ಮತ್ತೆ ಸ್ವಲ್ಪ ಸ್ಟ್ರೆಚಿಂಗ್ ಎಕ್ಸರ್ಸೈಸಸ್ ಮಾಡಿ, ಮತ್ತೆ ಮೊಣಕಾಲ್ ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಿ. ಮೊಣಕಾಲ್ ತುಂಬಾ ನೋವಿತ್ತಂದ್ರೆ ನೀವು ಮನೆಯಲ್ಲಿ ಸ್ಟಿಕ್ ಇಟ್ಕೊಂಡು ವಾಕ್ ಮಾಡಿ. ಮೆಟ್ಲೆಲ್ಲ ಸ್ವಲ್ಪ ಹತ್ತೋದು ನಿಲ್ಸಿ, ಇಂಡಿಯನ್ ಟಾಯ್ಲೆಟ್ಸ್ ನಿಲ್ಸಿ, ಮನೆಯಲ್ಲಿ ಕೆಳಗಡೆ ಕೂತ್ಕೊಂಡು ಪೂಜೆ ಮಾಡೋದು ನಿಲ್ಸಿ, ಒಂದ್ ಮಣೆ ಹಾಕೊಂಡು ಸ್ವಲ್ಪ ಕೂತ್ಕೊಬೇಕು. ಮತ್ತೆ ಮೊಣಕಾಲ್ಗಿಂತ ಕೆಳಗಡೆ ಇರೋ ದಿವಾನ ಅಂತದೆಲ್ಲ ಯೂಸ್ ಮಾಡಬೇಡಿ. ಸೊ ಕಾರ್ಟಿಲೇಜ್ ಸಪ್ಲಿಮೆಂಟ್ಸ್ ತಗೊಳ್ಳಿ. ಮತ್ತೆ ಬ್ಯಾಕ್ಗೂ ಸ್ವಲ್ಪ ಮಸಲ್ ರಿಲ್ಯಾಕ್ಸೇಷನ್ಸ್ ತಗೊಂಡು, ಆಮೇಲೆ ಕ್ಯಾಲ್ಸಿಯಂ, ನರದ ವಿಟಮಿನ್ B12, ಮತ್ತೆ ಕಾರ್ಟಿಲೇಜ್ಗೆ ಅಂತ ಕೆಲವು ಸಪ್ಲಿಮೆಂಟ್ಸ್ ಬರುತ್ತೆ, ಅದು ಕುರ್ಕುಮಿನ್ ಮತ್ತೆ ಬೋಸ್ವೆಲಿಯಾ ಅಂತ ಬರುತ್ತೆ. ಅದು ಅದ್ರಲ್ಲಿ ಪೇನು ಕಡಿಮೆ ಆಗುತ್ತೆ, ಅಂತದ್ ತಗೊಳ್ಳಿ. ಸೊ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಇಲ್ಲ, ನೋವು ಕಂಟ್ರೋಲ್ ಅಲ್ಲಿ ಇರುತ್ತೆ. ಸೊ ಇವೆಲ್ಲ ಮಾಡಿದ್ರೆ ನಿಮ್ಗೆ ಸ್ವಲ್ಪ ಮೇಂಟೈನ್ ಆಗುತ್ತೆ. ಜಾಯಿಂಟ್ ಅಲ್ಲಿ ಬೇಕಾದ್ರೆ ನಿಮ್ಗೆ ಜಾಯಿಂಟ್ ಚೆನ್ನಾಗಿತ್ತಂದ್ರೆ ಇಂಜೆಕ್ಷನ್ ಹಾಕ್ಸ್ಕೊಳ್ಳಿ. ಅದು
ಮಾಡಿಸ್ಕೊಂಡಿದ್ದೀನಿ ಡಾಕ್ಟರ್.
PRP ಹೆಲ್ಪ್ ಆಗಲ್ಲ ನಿಮ್ಗೆ, ಹೈಲೋನಿಕ್ ಆಸಿಡ್ ಹೆಲ್ಪ್ ಆಗುತ್ತೆ.
ಅದೇ PRP ನನ್ಗೊಂದು 4-5 months ಪರವಾಗಿಲ್ಲ, ಪೇನ್ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು.
ಅದು ಜೆಲ್ ಇಂಜೆಕ್ಷನ್ ಹಾಕೊಳ್ಳಿ. ಜೆಲ್ ಇಂಜೆಕ್ಷನ್ ಅದು ಮೂಳೆ ಉಜ್ಜೋದು, ಮೂಳೆ ಟಚ್ ಆಗೋದು ಸ್ವಲ್ಪ ಕಡಿಮೆ ಮಾಡುತ್ತೆ. ಸ್ವಲ್ಪ ನಿಮ್ಗೆ ಅದು ಅನುಕೂಲ ಆಗುತ್ತೆ.
ಡಿ ವಿಟಮಿನ್ ತಗೊಳಕ್ ಹೇಳಿದ್ರಲ್ಲ, ಎಷ್ಟು ದಿವಸ ತಗೋಬೇಕು?
ಡಿ ವಿಟಮಿನ್ ನೀವು ವಾರಕ್ಕೊಂದು 3 ತಿಂಗಳು ತಗೊಳ್ಳಿ, ಆಮೇಲೆ ತಿಂಗಳಿಗೊಂದು 1 ವರ್ಷ ತಗೊಳ್ಳಿ.
ಓಕೆ ಡಾಕ್ಟರ್. ಕ್ಯಾಲ್ಸಿಯಂ ತಗೊಂತಿದ್ದೀನಿ, 500 mg ತಗೊಂತಿದ್ದೀನಿ ಡಾಕ್ಟರ್.
500 ಸಾಲಲ್ಲ ನಿಮ್ಗೆ, ನಿಮ್ಗೆ ಅಟ್ಲೀಸ್ಟ್ 1 ಗ್ರಾಮ್ ಹಂಗ್ ಬೇಕು. ಅದು
1000 mg ತಗೋಬೇಕು.
1000 mg ತಗೊಳ್ಳಿ. ವಿತ್ ವಿಟಮಿನ್ ಡಿ ಬರುತ್ತೆ, ತಗೊಳ್ಳಿ. ಅದು 3 ತಿಂಗಳು ತಗೊಳ್ಳಿ. HD ತಗೊಳ್ಳಿ. 3 ತಿಂಗಳು ತಗೊಂಡು 1 ತಿಂಗಳು ಬಿಟ್ಬಿಡಿ, ಮತ್ತೆ 3 ತಿಂಗಳು ತಗೊಂಡು 1 ತಿಂಗಳು ಬಿಟ್ಬಿಡಿ, ಮತ್ತೆ 3 ತಿಂಗಳು ತಗೊಂಡು 1 ತಿಂಗಳು ಬಿಟ್ಬಿಡಿ.
ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಡಾಕ್ಟರ್. ಬ್ಯಾಂಗ್ಳೂರ್ಗೆ ಏನಾದ್ರು ಬಂದು ನಿಮ್ಮನ್ನ ಮೀಟ್ ಮಾಡ್ಬೇಕು?
ಬರ್ಬೋದು.
ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್.
Thank you, madam. Thank you very much. 1 minute, doctor. Anybody wants to talk to doctor now, please raise your hand, or you can unmute and talk now. Just a minute, sir. Sir, there is one more question actually. Can we give hyaluronic acid to diabetic patient?
Yeah. Hyaluronic acid can be given to diabetic patients. The only thing is, in diabetic patients, if they are uncontrolled, we don't have any other thing. Only local anesthesia and hyaluronic acid. There is absolutely no contraindication in diabetic patient. It has worked.
Okay, thank you, doctor. Thank you very much.
One more thing, and ಇದು lower back ಗೆ ಏನೋ ಟ್ಯಾಬ್ಲೆಟ್ ಹೇಳಿದ್ರೆ, ಅದು ಏನಾದ್ರೂ ನನಗೆ ಮೆಸೇಜ್.
ಅದು ಲೋವರ್ ಬ್ಯಾಕ್ ಗೆ ಅದು ಮಸಲ್ ರಿಲ್ಯಾಕ್ಸೆಂಟ್ಸ್. ಅದು ನಿಮ್ ಟೈಟ್ ಆಗಿರುವಂತ ಮಸಲ್ಸ್ ಗೆ ಅದು ಸ್ವಲ್ಪ ಅದು ರಿಲ್ಯಾಕ್ಸ್ ಮಾಡಕ್ಕೆ ಒಂದು ಹೆಲ್ಪ್ ಮಾಡುತ್ತೆ. ಅದನ್ನ ಆದ ನಂತರ ನೀವು ಬ್ಯಾಕ್ ಎಕ್ಸರ್ಸೈಸ್ ಮಾಡಬೇಕು. ಸೊ ಅದು ಮೆಸೇಜ್ ಅವ್ರ ನಂಬರ್ ಕೊಟ್ಟರೆ ನಾನು ಮೆಸೇಜ್ ಮಾಡ್ತೀನಿ, ಇಲ್ಲ ನನ್ನ ನಂಬರ್ ನೀವು ಮೆಸೇಜ್ ಮಾಡಿ, ನಾನು ಮೆಸೇಜ್ ಮಾಡ್ತೀನಿ.
ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್.
ಓಕೆ,
thank you very much, doctor. Mr. Shivakumar, you want to talk to doctor now? Please unmute and talk now. It's already getting late actually. Mr. Shivakumar, You are raised your hand. Hello. Okay.
Hello, am I audible?
Yes, sir. Yes.
Yes, yeah.
Good evening.
Good evening.
I am 76 years old and quite active. Go to even gym also. I can walk a lot, about 5 to 6 kilometers. But I have this left knee pain. Though I manage, but pain is there. It was long back, I think 30 years back, while kicking the motorcycle, I got little injured. I mean, I felt the pain. And since then, I'm managing without any serious problem. Of course, I'm taking calcium supplements and other vitamins also I'm taking, B complex. Just I'm worried, otherwise I'm hale and healthy. Except this knee in my body, there is no pain at all.
So you're having this knee pain on what activity? Is it always there, or climbing stairs?
Walking mainly.
Walking on a normal ground, or walking on a slope, climbing stairs, sitting and standing?
No. Generally walking also I have little. So slightly I put more weight on my right leg, and I manage. Afterwards it becomes less. But pain is there. Slight pain is there always.
So slight pain at your age is acceptable, and because you are very active, that is an exception. So it's good. So only thing all you have to do is to just do the quadriceps and inner thigh strengthening exercise.
Yeah,
you're already taking the calcium supplements.
10 to 15 squats almost daily.
See, squats is dangerous. Please don't do squats.
Okay.
If you want to do, you just do half squats. So squatting will increase the joint force. So it leads to more breakdown of cartilage. Your cartilage is also 76 years old. So that will also break very fast. So don't give the cartilage so much of load as a full squat. So do half squats and do the inner thigh strengthening exercise. Take cartilage supplements, and you can do hot fermentation at home. You can use a local analgesic spray and give hot fermentation, and avoid stairs, avoid Indian toilets. So do this little bit of modifications. I think you can just manage on your own.
But I am climbing 4 staircase daily without any much problem.
You were able to do it because your muscle is good.
Yeah,
eventually you're stressing out your joint, and this whatever pain you're facing now will eventually worsen, and then your 4 floors will come down to 2 floors, then your 2 floors will come down to 1 floor, and then you will be only within the level ground walking. So you have to maintain these 4 floors. You just reduce your 4 floors to 3 floors, and just decrease whatever you're doing now by at least 10 or 20%. Concentrate on building your knee strength and your bone strength, and take a vitamin D tablet weekly once, which will also help. And I think you should be able to manage on your own session.
Thank you, doctor. Will this braces help me?
Yeah, definitely. Braces will help you to climb 1 more floor, actually.
So I'll try.
Try it, sir. Please try.
Thank you, doctor. Thanks. So nice.
Okay.
Thank you very much, doctor. Thank you, Mr. Shukma. Thank you. Is there any other question? Anybody wants to talk to? Okay. Sir, finally, only one more question from my side, doctor. Because when you are presenting about the root tear, especially on the this one, meniscus root tear,
yes,
you said that it is not visible sometimes in the MRI. But how should we able to understand?
MRI, sometimes they will report it, sometimes they will not report it.
Okay.
So what happens is the radiologist will look at the meniscus as a whole, and they will report. So MRI for meniscus is 80% accurate, 20% still there will be flaws.
Okay.
So clinical examination and patient symptoms, and when you look at the MRI and assess where the patient is pointing out for pain, and then look at the MRI at that particular point, then you will be able to sometimes pick up a root tear or a backside of the knee that is called as a ramp tear. So all those things. So even when we do an arthroscopy, if we generally look at the common structures which are damaged, we will just miss out them to grade 4 very fast if they are ignored. So even if the patient is 60, recently in Osmet I operated a lady who was 69 with a root tear with a grade 2 arthritis at the age of 69. So the MRI we were able to diagnose, and first she came with the left knee, and I told her that it might work for a few years and then she will need a joint replacement. But very next year she came back and did the second knee also root tear. She did an MRI, found that it was the same symptoms. So both the knee at the age of 69 and 70, she underwent an arthroscopic root repair. So, and now she's actually comfortable. She's quality of life has improved. The knee pain, acute knee pain has reduced. It's only the little bit of knee pain because of arthritis she's having. She's taken the gel injection, and she's from Kerala and she's doing good. So now that emphasis on repairing the root is there. Initially we used to just trim the meniscus. Now we are trying to preserve the meniscus as much as possible.
Thank you, Doctor. Wonderful, Doctor. Really very good news, actually. So, participant, please understand that you should identify the root cause first of all. Always take the consultation with the orthopedic surgeon. It is not mean that to any doctor you should go with the proper orthopedic surgeon consultation. That is always will help you to get a good results. Okay. So don't take any decision on your own and all. That is what the small request from our side actually. So if any questions from your side, otherwise we'll wind up. I think there is no question, I think, from anyone, Doctor. So thank you very much, Doctor, for your, I think almost we are planned to do only 1 hour. I think almost additionally 30 minutes we are extended actually. Thank you for your patience, and you are explained everything in a very detailed manner, and you are explained to the patient's queries also. Very nicely you are explained to that. Maybe we are going to share all the contact details, how to meet the doctor, how to get the appointment. Okay. All the details we are going to share it in the group. So please. And additionally, if somebody is not able to see the this webinar, we are going to share the webinar link also. In the YouTube link is there. We will share it soon. If you want to see the webinar again also, you can listen also. So on behalf of everyone, I really appreciate, Doctor. Thank you very much for spending more time with us and to the patient. And thank you very much for everyone for joining this webinar. Thank you very much, Doctor.
Thank you.
Thank you.
Thank you, Doctor.